Well, good morning, everyone. I'd encourage you all to come in. There's plenty of room on this side of the hall. I'm Meg Jardine from Sydney, Australia, and my co-chair.
I'm Swapnil Hirmat from University of Ottawa in Canada.
And we'd like to welcome you to this year's first late-breaking clinical trials session. This year, the format is a little different. We have two clinical trials session, late-breaking clinical trials sessions. As well, we have some talks in the afternoons, again with late-breaking presentations. So we'd encourage you all to give your feedback on the new format and let us know what you like and what you don't like. I'll encourage you all to look at the faculty disclosures as they come through. And be aware that this session is being recorded and will be available in late November through the ASN e-learning centre. There will be evaluations and credits. You can give evaluations in your comments through the app this time or through other forums, and be assured that we will be reviewing them all and planning for next year. I'd ask you all to silence your phones and get ready, have them out though, and get ready for the Q&A. There's a Q&A, a QR code, which will be up for you to give your feedback, or else you can look through the ASN Kidney Week app and use the click the link on this session's page. Your questions will come through and be anonymous. You'll also be able to up-rank previous questions that are there if you think they are particularly important, and that will help us direct the questions in the way that's most useful to the audience. So I'd encourage you all to keep moving in and find your seats, and we'll commence with our first presentation, which will be from Finian McCausland on finerenone and kidney outcomes in patients with heart failure, the Fine Arts HF trial. Thank you, Finian.
Okay, thank you. Good morning, everybody. It's my pleasure to be here. Thank you for the committee for the invitation to present. And on behalf of our co-authors and the Fine Arts Heart Failure investigators, I'm presenting finerenone and kidney outcomes in patients with heart failure with mildly reduced or preserved ejection fraction. And this is data from the Fine Arts Heart Failure trial. So the rationale, chronic kidney disease is present in around 50% of patients with heart failure with mildly reduced or preserved ejection fraction, and is associated with higher morbidity and mortality compared to those without chronic kidney disease. Among patients with heart failure with mildly reduced or preserved EF, the presence and magnitude of albuminuria is a potent predictor of both cardiovascular and kidney adverse outcomes. Finerenone, which is a non-steroidal mineralocorticoid receptor antagonist, has proven efficacy in reducing kidney disease progression among patients with chronic kidney disease, type 2 diabetes, and albuminuria, and was recently observed to lower the risk of heart failure events and cardiovascular death among patients with heart failure with mildly reduced and preserved ejection fraction in the Fine Arts Heart Failure trial. Herein, we explore the effects of finerenone on kidney outcomes in more detail using data from the Fine Arts Heart Failure trial itself. In terms of the Fine Arts study design, this was a randomized, double-blind, placebo-controlled trial of patients with heart failure with mildly reduced or preserved ejection fraction. The key inclusion criteria for this trial were those with symptomatic heart failure with left ventricular ejection fraction of 40% or greater, an age of 40 years or greater, elevated natriuretic peptide levels, evidence of structural heart disease, which included left atrial enlargement or left ventricular hypertrophy, and the use of diuretics to treat heart failure in the 30 days prior to the randomization. The key exclusion criteria, which are relevant to this study, include an eGFR of less than 25 mils per minute per 1.73 meters squared, serum potassium of greater than 5 millimoles per liter, a hemoglobin of less than 10 grams per deciliter, symptomatic hypotension, or the use of an MRA in the 30 days prior to randomization. Eligible patients were randomized in a 1-to-1 fashion to either finerenone or matching placebo. The finerenone doses were titrated according to the baseline eGFR. So patients with an eGFR of less than 60 were initiated on 10 milligrams per day and titrated to a maximum of 20. Those with a baseline eGFR of greater than 60 mils per minute were initiated on 20 milligrams of finerenone per day and titrated as tolerated to a maximum of 40 milligrams per day. The titration was drug was up titrated to maximally tolerated doses if the potassium was less than 5 millimoles per liter and the eGFR decrease was less than 30%. A total of 6,001 patients were validly randomized, and visits occurred at baseline, month 1, every 3 months for the first 12 months, and every 4 months thereafter. In terms of the endpoints, the primary endpoint for the parent study was the composite outcome of cardiovascular death and total heart failure events, which consisted of heart failure hospitalizations and urgent visits. This was already reported in the parent study in the New England with a significant 16% reduction in the overall risk. Today, we're concentrating on the endpoints related to the kidney outcomes, and these include the kidney composite endpoint, which was defined as the initiation of long-term dialysis or kidney transplantation. Both of these were adjudicated by a blinded clinical endpoints committee. A sustained eGFR decline of 50% or greater, and a sustained eGFR of less than 15 mils per minute per 1.73 meters squared. In an additional pre-specified sensitivity analysis, we examined a more restrictive definition for the sustained decline in eGFR of 57% or greater, which is equivalent to a doubling of serum creatinine. We also examined the frequency of new onset micro and macroalbuminuria. Microalbuminuria was defined as a urine albumin to creatinine ratio of 30 milligrams per gram or greater. Macroalbuminuria was defined as a new onset USCR of 300 milligrams per gram or greater. Additionally, we explored the changes from baseline in the eGFR and the urine albumin to creatinine ratio over time. In terms of patient flow, over 7,400 patients were assessed for eligibility. A total of 6,016 were randomized, 3,011 to finerenone and 3,005 to placebo. A small number of patients were excluded due to either invalid randomization or good clinical practice violations, leaving a full analysis set of 3,003 in the finerenone arm and 2,998 in the placebo arm. In terms of discontinuations during the study, these were pretty similar, with around 20% in the finerenone arm and 21% in the placebo arm. A total of 6 and 7 patients respectively withdrew consent during the study, and only 1 patient was lost to follow-up in the finerenone arm, and 5 patients lost to follow-up in the placebo arm. Here I present the baseline characteristics according to the categories of baseline eGFR, and within those categories according to the randomized treatment arms. The first 2 columns are those with an eGFR at baseline of 60 mils per minute or greater. The middle 2 columns an eGFR of 45 to 60, and the last 2 columns those with an eGFR of less than 45. A couple of points of note. As expected, those with the lower eGFR category tended to be older, more commonly female, and more commonly have a history of diabetes, although these were all relatively well balanced between the placebo and finerenone groups within each subcategory. This was a predominantly Caucasian study with around 80% of white. Systolic blood pressure was pretty similar across all the categories considered at around 130 millimeters of mercury. By definition, according to these categories, serum creatinine was higher and eGFR was lower across these categories. Urine albumin to creatinine ratio was relatively low in this study, and particularly in comparison to the other studies of patients with chronic kidney disease and type 2 diabetes with finerenone. And so the urine SER in this study median was around 18 milligrams per gram, again, which is in the normal albuminuria range. Serum potassium averaged about 4.3 to 4.4 millimoles per liter. Left ventricular ejection fraction around 53%. And again, not surprisingly, the concentrations of NT-proBNP were higher in those in the lower eGFR categories, but again, relatively well balanced across the randomized treatment. To give you a little bit more background in terms of the baseline medication use, again, according to the categories and within the finerenone and placebo arms, beta blocker use was approximately 85%, angiotensin converting enzyme inhibitor use around 40%, but it was a little bit lower in those with a lower eGFR. Angiotensin receptor blockers were used around 35% on average. Angiotensin receptor neprilysin inhibitors, a little bit lower, around 8% on average. Sodium glucose cotransporter 2 inhibitors, around 12%. Loop diuretics were pretty common and around 90% across the population. So the results of the renal composite outcome, again, to remind you, this is long-term dialysis or transplant, a sustained eGFR of 50% or greater, and a sustained eGFR of less than 15. These results were part of the primary analysis. This was a key pre-specified secondary outcome, and it was already presented. But here, to remind you all, the overall number of events was relatively modest in this low-risk population, so that the number of events in the placebo arm was 55, or 1.8%. The number of events in finerenone was 75, or 2.5%, with rates per 100 patient years of 0.9 and 1.2 respectively, giving a non-significant hazard of 1.33, with a lower confidence bound of 0.94 and an upper bound of 1.89. We then explored the other pre-specified composite outcome here, including a more restrictive definition of an eGFR decline sustained of 57% or greater. As expected, the number of events were fewer. So there were 31 events in the placebo arm, or 1%, 41 in the finerenone arm, or 1.4%, with rates that were half of that seen in the other kidney composite. So rates per 100 patient years of 0.5 and 0.6 respectively. And again, a non-significant and mildly attenuated hazard of 1.28, with a lower confidence bound of 0.8 and an upper confidence bound that just exceeded 2. We subsequently examined the change in eGFR over time, and here are the curves. The y-axis is the change in eGFR from baseline in mils per minute per 1.73 meters squared. The red line is placebo, the blue line is finerenone, and the x-axis is months in the duration of the study from randomization. You can see from the blue line that there's an early eGFR decline, which was expected given the mechanism of action with finerenone. The placebo decline was 0.1, the finerenone decline 3 mils in the first 3 months, giving a difference of 2.9 mils per minute. The curve for the placebo arm was notable in that it was quite shallow. So from 3 months to the end of study in this chronic curve, the placebo arm declined at 1.1 mils per minute per year. The finerenone similarly at 0.9 mils per minute per year, with a non-significant difference between the two arms of 0.2 mils per minute per year. In terms of changes in USCR over time, present a similar curve. Here, the y-axis is the percent change in USCR from baseline. The red again is placebo and the blue finerenone. And you can see that there is an early and sustained decline in urine albumin to creatinine ratio upon initiation and titration of finerenone over the first 6 months, such that the USCR was 30% lower at 6 months for finerenone relative to placebo. And again, the separation was sustained throughout the course of follow-up. We then took this further and examined new onset micro and macroalbuminuria. Here are the presentations for those with restricted to those 3,500 patients with baseline USCR of less than 30 milligrams per gram, placebo in red and finerenone in blue. And you see an early and sustained separation of these curves in favor of finerenone. So there were 742 events of new onset microalbuminuria with finerenone versus 884 with placebo for a significant hazard ratio of 0.74. So that's a 24% risk reduction in the development of new onset microalbuminuria. In terms of macroalbuminuria, here these analyses were restricted to the 5,223 patients with a baseline USCR of less than 300 milligrams per gram. And we see a similar pattern, although a lower number of events, where there was an early separation and sustained separation of the curves, again in favor of finerenone. So 250 events versus 386 events for a significant hazard ratio of 0.62, which is a 38% risk reduction in the development of new onset macroalbuminuria in favor of finerenone. Here are some of the safety parameters, again presented according to the categories of eGFR at baseline and within the treatment arms. You can see that the number of serious adverse events, not unexpectedly, was higher in the lower eGFR categories, reflecting a sicker population. and the relative number of adverse safety events were similar between the treatment arms across all eGFR categories. In terms of elevations of serum creatinine, investigator reported acute kidney injury and AKI that led to hospitalization. These tended to be more frequent in the finerenone versus the placebo arms, but with similar patterns across the categories of eGFR. Similar to those reported in the parent study, finerenone as a non-steroidal mineralocorticoid receptor antagonist does elevate serum potassium to some extent. These were, again, more common in the finerenone versus the placebo arms, but with similar patterns across all levels of eGFR categories. And reassuringly, hyperkalemia that led to hospitalization was exceedingly rare, and during the study, there were no hyperkalemic-related deaths. Systolic blood pressure, again, was a little bit more frequent in those with finerenone versus placebo across all of the eGFR categories considered. So in conclusion, among patients with heart failure with mildly reduced or preserved ejection fraction in FINE-ARTS HF, who were at relatively low risk of adverse kidney events, finerenone did not alter the frequency of the pre-specified kidney composite outcome. Finerenone caused an initial expected decline in eGFR, but did not alter long-term eGFR trajectory compared with placebo. Finerenone caused an early and sustained lowering of albuminuria and lowered the risk of new-onset micro and macroalbuminuria. Hyperkalemic episodes were more common with finerenone than with placebo, with similar patterns across eGFR categories. And overall, these data provide important information on the expected change in kidney biomarkers when prescribing finerenone for patients with heart failure with mildly reduced or preserved ejection fraction. Again, on behalf of the steering committee and all of the committees involved, I'd like to thank everybody who made this study possible. A particular shout out to Scott Solomon and John McMurray as the co-chairs, the sponsor leadership by Bayer, our clinical events, data safety monitoring and independent statistical teams, our national lead investigators, and of course, all of the patients who made this study possible in the first place. These studies are now hopefully simultaneously available, published in the Journal of the American College of Cardiology. You can use this QR code. And on the right-hand side, we have our FINE-ARTS heart failure website, where you can look up all the publications that have emanated from this study so far. Thank you very much.
This presentation is subject for an independent discussant, so I'll ask Dr. Ian de Boer to come to the podium.
Good morning. Here are my disclosures. And I'd like to start by thanking the organizers for inviting me to comment on this presentation and commend the FINE-ARTS HF investigators for providing rigorous randomized clinical trial data to help guide the management of our patients with many comorbidities, including CKD, type 2 diabetes, and heart failure. And during this commentary, I hope to accomplish two tasks. One is to provide context for the results that Dr. McCausland just presented, and two, to address my interpretation of the question that is commonly asked, who should be prescribed finerenone in light of these new data? I'll start by summarizing my interpretation of the data presented by Dr. McCausland. So starting on the left, it seems clear that finerenone causes hemodynamic effects in the kidney. That's evidenced by the 2.9 mils per minute dip in eGFR within the first 1 to 3 months after initiation, and the albuminuria reduction of 30%. These are expected based on the known mechanism of action of finerenone and prior data. They are of substantial magnitude, perhaps larger than I would have expected, perhaps because the doses of finerenone used in this trial are larger than has been used in prior trials or application to this heart failure population. With regard to the incident micro and macroalbuminuria outcomes, it's possible that these do reflect long-term effects of the drug, but they may also be explained by these hemodynamic effects. Essentially, by shifting the distribution of urine ACR to lower values, participants in the finerenone group are moved further from the goalposts defining the thresholds for microalbuminuria and macroalbuminuria, and could take longer and be less likely to reach those goalposts for that reason. With regard to the long-term effects over the 3 years of follow-up in Fine Arts HF, Dr. McCausland noted there's no benefit in the primary kidney composite outcome. Part of this could also be related to the hemodynamic effects by shifting the distribution of eGFR to lower values. That could be, in this case, moving participants in the finerenone arm closer to the goalposts of 40% or 50 or 57% decline, and explain the trend to harm with the hazard ratio point estimate that was greater than 1. It is important to note that there's uncertainty in this estimate due to a low number of events because of the low kidney risk of the population. It is also important to note that the null result, no benefit for long-term kidney outcomes, was robust in the chronic eGFR slope analyses that were presented. And also, I'd like to note that chronic kidney disease is a disease that, of course, progresses over years to decades. We had relatively short follow-up, and the long-term effects of finerenone in this population do have some uncertainty. One could speculate that with albuminuria lowering, there may ultimately be longer-term eGFR benefits, but I would state that or offer that substantial eGFR benefits are unlikely in this low-risk kidney population based on the results we've seen. And finally, there were hyperkalemia and AKI episodes expected. These are expected based on mechanism of action prior data. The incidence was low, particularly among people with normal eGFR in the setting of close monitoring. The incidence was higher with lower eGFR. And I think that as we implement finerenone, we do need to pay attention to subject selection and monitoring to reduce the risk of these adverse events. All right, so for context, I'd like to start with 2 prior trials that were published, the Fidelio DKD and Figaro DKD trials. These were in a higher kidney risk population, people with type 2 diabetes and CKD manifest as albuminuria despite RAS inhibitors. The Fidelio and Figaro trials had kidney and cardiovascular outcomes. They were combined into a pre-planned individual level analysis called Fidelity. You can see here the kidney risk and cardiovascular risk on the KDIGO heat maps of the individual trials in the Fidelity population. And I'll present some summary data from the Fidelity trial that provides the best estimates of effects of finerenone in this higher risk kidney population. So in the red circle here, you'll see the effect of finerenone versus placebo on a kidney composite outcome, similar to what Dr. McCausland presented. An eGFR decline of 57% or more, kidney failure or renal death. And you can see in the Fidelity population, this was reduced by 23%. There were also cardiovascular benefits driven by benefits with reduction of hospitalization for heart failure. So the Fidelity data, just to remind everyone, do show kidney benefits in this higher kidney risk population with type 2 diabetes and albuminuria. And I'd also like to point out, again, the primary results of the Fine Arts HF trial published in print this week in New England Journal of Medicine. The primary outcome was total worsening heart failure events and death from cardiovascular causes. Individual participants could contribute multiple events. The result is in a rate ratio, which was 0.84, reflecting a 16% reduction in heart failure events or cardiovascular death. So this confirms that in the heart failure population, there are cardiovascular benefits. The third context I'd like to provide is that of SGLT2 inhibitors, and we are now in a period of time when combination therapies are critical. And in fact, SGLT2 inhibitors are standard of care now for patients with chronic kidney disease who have type 2 diabetes, proteinuria, or heart failure, as well as standard of care for patients who have heart failure with any level of ejection fraction. And thinking about how these drugs interact with finerenone is important. Here you can see a nice summary through meta-analysis of the large volume of data we now have available addressing SGLT2 inhibitors. And you can see the very large magnitude of reduction in risk of CKD progression of 37%, as well as reductions in the risks of AKI, heart failure, and cardiovascular death. And I point out in the red circle here that this is observed across trials with a large range of kidney risk at baseline, shown here as a baseline mean eGFR from 36 to 86 mils per minute, and a rate of kidney composite outcomes in the placebo group ranging a full order of magnitude from 3 to 60 per 1,000 patient years. It does seem that finerenone and SGLT2 inhibitor appear to have independent kidney and cardiovascular effects. More research on combination actions are important, but we have some data published here from the Fidelity trial or data set that I noted earlier. And you can see that while the number of users of SGLT2 inhibitor at baseline in the Fidelity data set, which is about 7% of that population, is low, and the number of events in that group was low, the cardiovascular and kidney effects appear to be similar among people who were using SGLT2 inhibitors at baseline. So I'll summarize with this last slide and try to address this question of my opinion of who should be prescribed finerenone. And I do want to go back and start with the Figaro and Fidelity and Fidelio data and remind us that for people with type 2 diabetes and kidney disease who have residual albuminuria and are at high kidney risk, we can start finerenone and expect kidney and heart failure benefits. This is for people with type 2 diabetes and residual albuminuria. In my practice, this means residual albuminuria with an ACR of 30 milligrams per gram or more, despite treatment with RAS inhibitor and an SGLT2 inhibitor. The new contribution of FineArts HF is, of course, focused on heart failure and patients with heart failure with moderately reduced or preserved ejection fraction. And we now know that despite no large kidney benefits in this population, there are heart failure benefits, and this will lead to increasing use of finerenone in this population. There is debate already in the cardiology field about whether to use a non-steroidal or steroidal mineralocorticoid receptor antagonist in this population. I will not go into great detail on that debate, but I think most will agree that having a new tool to treat moderately reduced and preserved ejection heart failure is valuable. And we do, as I noted, need to pay attention to patient selection and monitoring. And I do believe we should follow the eligibility criteria of these trials, focusing on patients who have an eGFR 25 mils per minute or more, normal serum potassium at assessment, and perhaps also think about AKI risk and avoiding patients who have a history of recurrent AKI. Monitoring over time after initiating finerenone is also important to hope and maintain the reasonable side effect profile that's been observed in the trial when translated into clinical practice. I'll end there. Again, thank you for the opportunity to comment on this paper, and thank you for your attention.
Thank you, Dr. De Boer. We'll now move straight on to the next presentation, and I'd ask Dr. Abinat Mathiasakaliou to come to the podium and present personalised recommendations for AKI using a kidney action team, a multi-centre randomised controlled trial. Thank you.
Good morning, everyone. On behalf of the CAD-AKI investigators, it is my honor to present our trial entitled Personalized Rapid Recommendations for Acute Kidney Injury Using a Kidney Action Team. The study was supported by the Agency for Healthcare Research Quality of the U.S. Department of Health and Human Services, with funding awarded to Dr. Perry Wilson. As a background, in-hospital AKI is common and associated with worse outcomes. And so AKI affects about 1 in 5 hospitalized patients, and it's associated with elevated risk of mortality, chronic kidney disease and chronic kidney disease progression, and increased hospital costs. Clinical decision support tools such as electronic alerts have improved adherence to best practice and patient outcomes in conditions such as sepsis and venous thromboembolism, as an example. And they've been emerged as an attractive tool to improve outcomes in our patients with AKI and have been incorporated in the standard of care of AKI care in some countries. In non-randomized pre-post implementation type studies, electronic AKI alerts were associated with reduced risk of AKI progression and mortality. However, in large randomized clinical trials, such as shown in these two, the first including 6,000 hospitalized patients with AKI, showed no difference in the primary composite outcome of AKI progression, dialysis, or death within 14 days from AKI detection, or a maximum change in eGFR in 7 days, and a mixed improvement in best practice implementation. So we postulated that this could be because of unintended effects of alerts, or because of lack of confidence or experience in managing AKI by general clinicians. So with that background, the CAT AKI was designed to investigate if rapid, real-time AKI detection and accompanied by recommendation from a dedicated physician and pharmacist team, giving recommendations in these specific areas, specifically general diagnostics for AKI, volume, potassium, acid base, and medications, if that could lead to improvement in hospital mortality and AKI progression. The CAT AKI was a multi-center randomized clinical trial, including 4,003 hospitalized adults, randomized 1-to-1 to intervention, that is a recommendation note, or usual care. 2 hospital systems participated, including Yale and Johns Hopkins, including 7 hospitals in the states of Connecticut, Maryland, and Rhode Island in the US. The study was conducted between October 2021 and February 2024. Here's the enrollment and randomization process. As soon as an adult hospitalized patient meets KDIGO stage 1 or higher AKI criteria, an alert is triggered and sent to one physician and 1 pharmacist kidney action team scheduled to enroll during that specific time. That team reviews the chart and screens for eligibility. They create recommendations and all patients who meet eligibility. And then the person who finishes last randomizes the patient to either receive the intervention, which is a recommendation note, or no recommendation. The goal time from AKI detection to randomization was 1 to 2 hours, and the CAT made recommendations only in actions that, if the actions were not implemented already. Recommendation instruments were structured in this format with multiple checkboxes for recommendation entry efficiency. Once both parties completed their recommendation entry, a note was instantaneously created combining all recommendation categories and if the patient was randomized to intervention. And this note was placed in the EHR, and providers were notified. The primary clinical outcome was a composite of death, dialysis, and AKI progression to a higher stage within 14 days of AKI detection. The process outcome was a proportion of recommendations implemented in 24 hours. That is the proportion of implemented to delivered recommendations in the intervention arm versus the proportion of implemented to undelivered recommendations in the usual care arm. Pre-specified secondary outcomes included individual components of the composite outcome, as well as nephrology consult within 14 days from AKI detection. Over the course of 2 years and 3 months, we screened 6,082 patients and enrolled 4,003. Here are some baseline characteristics, and baseline characteristics were all balanced. The median age was 72, 81% had hypertension, 40% had CKD. The median serum creatinine was 1.5 milligrams per deciliter. 80% of the patients were enrolled at Yale and 20% were enrolled at Hopkins. 50% of the patients were on a general medical floor, and 20% were in an ICU. Baseline characteristics continued. The kidney action team made 14,539 recommendations in total in all patients, with a median of 3 recommendations per patient. The time from AKI detection to randomization was 56 minutes. Most patients had at least one recommendation in the general diagnosis and monitoring area, which may include ordering a urinalysis, a renal ultrasound, checking for pigment nephropathy, or proteinuria. Volume recommendations were provided in 80% of the patients, and these may include ordering IV fluids or discontinuing IV fluids, ordering or discontinuing diuretics, ordering a chest x-ray, echocardiogram, and so on. Potassium, acid-base, and renal consult recommendations were made in 16%, 10%, and 2% of the patients. Medication recommendations were made in over 50% of the patients. I'll present the process outcomes first. So as a reminder, the Kidney Action Team made 14,500 recommendations in all patients prior to randomization. We monitored implementation of these recommendations within 24 hours in both the intervention and usual care groups to assess differences in adherence. So within 24 hours of randomization, compared to the usual care group, CAT recommendations were implemented in 24 hours at a significantly higher rate in the intervention group. There was a significantly higher implementation of general diagnosis and monitoring recommendations at about doubling of the usual care. There was no difference in the volume, potassium, or acid-base recommendation implementations. There was a significantly higher implementation of medication recommendations in the usual care arm, in the intervention arm, compared to the usual care arm. Specifically, within 24 hours, the implementation of or ordering of urinalysis, urine protein creatinine ratio, bladder scan, renal ultrasound, and creatine kinase were significantly higher in the intervention arm when these recommendations were made by the Kidney Action Team. Now for the primary outcome. So the primary outcome was AKI progression to a higher stage, dialysis or mortality within 14 days of AKI detection. There was no difference in the primary outcome between the two groups. There was no difference in AKI progression to a higher stage, mortality, or dialysis. There was a trend towards a higher nephrology consult in the intervention arm. Now, our study had some limitations. The intervention is a set of recommendations that's dependent on the patient's clinical team. Checking the EHR and agreeing with the recommendations within the right amount of time and implementing the recommendations. And the Kidney Action Team did not provide further follow-up or examine study patients, and the Kidney Action Team did not enroll at all hours of the day. However, our study had multiple strengths. These were actionable recommendations rather than alerts, which have been associated with increased cost, alert fatigue, clinical care disruption. And our recommendations were delivered within 1 hour of AKI detection. We had a diverse patient population, a mix of services and of teaching and non-teaching hospitals. Our providers were notified once at the time of note entry, and we performed detailed implementation tracking in both groups. In summary, rapid personalized recommendation delivery for AKI from a physician and a pharmacist team was feasible. Recommendations from a Kidney Action Team improved the rate of AKI best practice implementation within 24 hours. However, the intervention did not lead to improved patient outcomes. I would like to acknowledge the study PI, Dr. Perry Wilson, Hopkins site PI, Dr. Parikh, and all AKI investigators and support staff. Full results of the study and further analyses are now available on JAMA. And I'd be happy to take any questions.
Thank you for that presentation. We do have a bunch of questions. Again, a reminder, the questions are through the app or the QR code that you see over there. There are a couple of questions about the recommendations or the implementation of recommendations in the usual care group. So if we understand right, there were no recommendations given to the usual care group. So what do those data represent?
That's correct. Thank you for that question. We made recommendations, or the Kidney Action Team made recommendations for all patients prior to randomization. And that note, the recommendation note, was delivered only to the patients who were randomized to intervention, but we stored all the recommendations made in all patients, regardless of the randomization status. So our best estimate of adherence was comparing the implementation of those recommended, pre-randomization recommended interventions between those randomization groups.
Excellent. There were volume recommendations that were also given, but the Kidney Action Team didn't actually examine the patients. So were they based on some kind of chart review process?
Yes, thank you for that question as well. We had trained all Kidney Action Team providers. So these providers were, I shouldn't say providers, but Kidney Action Team physicians were trained in AKI evaluation and management. We made sure to let them know to be cautious when they make any volume administration recommendations. They were required to look at intake and output documentation, weight trends, notes of physical exam from that day, and trends as well. All the recommendations that were placed in those checkboxes also had a cautionary statement that the actual team should evaluate the patient before following these recommendations.
Thank you. There are a couple of questions about the heterogeneity. So in a previous trial, I think you had included community hospitals. Was this just in academic hospitals? And how would you think about the application of this perhaps to community hospitals?
We included community hospitals as well. 2 of the 7 hospitals were community hospitals, same as the prior study.
And there was no heterogeneity of effect seen between community hospitals, or
there was none. We did subgroup analyses of the primary outcome compared it between non-teaching and teaching hospitals, and the primary outcome was not different.
Excellent. And there's another question about the uptake. Was there any analysis of the different uptake of recommendations between providers? For example, whether it was a APP versus a physician or the specialization, did that matter on how the uptake of the process of care was done?
As far as uptake, we don't have this data on everyone, but we had incorporated a link to a survey, a unique link to a survey within these notes, and had encouraged the covering provider, the provider that's mainly taking care of the patient, to go into these links and provide recommendations or provide their feedback. And we had 80% of those patients who filled out, not patients, the providers who filled out those surveys, about 190 people from various services, say that it was helpful. It helped them detect AKI early. We've included these data in the manuscript, and that's in there. As far as recommendation, or as far as the primary outcome, also across the different services, there was no difference in the primary outcome. Yeah.
Excellent. Thank you for that again, and congratulations on this fantastic study.
Thank you so much.
Our next presentation is on effects of semaglutide on kidney parameters in patients with obesity and non-diabetic CKD, presented by Dr. Hidde Hisspink. Thank you.
Good morning, ladies and gentlemen. And I would like to thank the Kidney Week organizers for giving us the opportunity to present the results of this investigator-initiated clinical trial designed to assess the effects of the GLP-1 receptor agonist semaglutide in patients with chronic kidney disease. I have to go back now. I have the privilege to present these data on behalf of all SMART investigators, and their names are listed here. These are my disclosures. Semaglutide, a GLP-1 receptor agonist, is indicated for the treatment of type 2 diabetes at a dose of 1 milligram per week. For patients with overweight or obesity, semaglutide is indicated for weight management at a dose of 2.4 milligram per week. The results of the FLOW trial demonstrated earlier this year that semaglutide reduced the risk of a composite clinical kidney endpoint by 24% in patients with type 2 diabetes and chronic kidney disease. And in that trial, semaglutide was used at a dose of 1 milligram per week. We also demonstrated that semaglutide at a dose of 2.4 milligram per week in patients with type 2 diabetes and overweight or obesity reduced albuminuria compared to placebo by about 28%. In these clinical trials, eGFR was also measured and estimated with estimation equations using creatinine or cystatin C. However, we know that in the setting of weight loss and lean body mass loss or fat mass, these estimation equations can be biased. Against this background, we designed the SMART trial, a clinical trial with the hypothesis that the treatment with semaglutide, 2.4 milligram per week, will reduce albuminuria, body weight, and blood pressure compared to placebo in patients with chronic kidney disease without diabetes and with overweight or obesity. So the objective of the trial was to assess whether treatment with semaglutide compared with placebo reduced albuminuria in people with chronic kidney disease without type 2 diabetes, with overweight or obesity, already receiving standard of care, including an ACE inhibitor or angiotensin receptor blocker. The primary outcome of the trial was the change from baseline in log-transformed urinary albumin to creatinine ratio, UACR, after 24 weeks of treatment. Secondary outcomes included change from baseline to week 24 in creatinine, cystatin C, eGFR, iohexol measured GFR in a subgroup of 47 participants, changes in systolic, diastolic blood pressure, body weight, waist circumference, and high sensitivity CRP. The trial enrolled adults with a diagnosis of chronic kidney disease defined as a GFR above 25 mL per minute and a urinary albumin to creatinine ratio between 30 and 3,500 milligram per gram. And all these participants had overweight or obesity with a body mass index greater or equal than 27 kilogram per square meter body surface area. We excluded participants with type 1 or type 2 diabetes, participants with an HbA1c above 6.5%, cardiovascular disease history within 3 months of study enrollment, or acute pancreatitis. These participants were then screened and enrolled and randomized to 24 weeks treatment with semaglutide 2.4 milligram per week, up-titrated over 16 weeks, or placebo. And after 24 weeks of treatment, these participants were continuing in a follow-up period of 4 weeks. The study was conducted in 13 hospitals located in Canada, Germany, Spain, and the Netherlands. We assessed 125 participants for eligibility. 24 screen failed, so we randomized 101 individuals. All these participants received study medication. During follow-up, 2 participants discontinued the medication, 1 in each treatment arm. and 4 participants in each treatment arm did not complete the study. So at the end, 47 participants completed the study in the semaglutide arm and 46 in the placebo arm. The baseline characteristics of the population are shown here. Mean age was around 55 years. About 35% were female. You can see the CKD etiologies: glomerulonephritis, hypertensive ischemic CKD, obesity-related chronic kidney disease as defined by the investigator and reported by the investigator. Mean body weight, around 105 kilogram. Waist circumference, around 116 centimeters. Systolic blood pressure, around 130. Mean eGFR, 64 mils per minute. And the median UACR at baseline was 251 milligram per gram creatinine. And around 20% of patients were using an SGLT2 inhibitor. And this is the primary outcome of the trial. Over time, semaglutide, compared to placebo, reduced albuminuria. And after 24 weeks of treatment, the difference between the semaglutide and the placebo arm was 52%. This effect was sustained throughout the 4 weeks washout period. What you can also appreciate from the slide is that the albuminuria level stepwise decreased at each dose titration step, and then reached the maximum effect after 24 weeks of treatment. The effect of semaglutide on albuminuria was consistent in all pre-specified subgroups. So when we analyzed the data by CKD etiology, we found consistent effects in the different etiologies, similar effects in people with a baseline eGFR above or below 60 mils per minute, and similar effects in those with a UACR above or below 300 milligram per gram creatinine. At the bottom, you can see the effects in those already receiving an SGLT2 inhibitor at baseline, and also in that subgroup analysis, we found consistent effects of semaglutide when added on top of an SGLT2 inhibitor. Now, looking at the effects of semaglutide compared to placebo on eGFR or mGFR, on the left you see the creatinine estimated eGFR data. Semaglutide initially reduced eGFR with the maximum effect achieved after 8 weeks, and then the eGFR levels increased again, so that after 24 weeks of treatment there was no difference between the placebo group and the semaglutide group. There were no changes over time in the cystatin C eGFR in the semaglutide group. After 24 weeks treatment, no difference with placebo. And when we measured GFR with iohexol, there were modest increases both in the placebo group and in the semaglutide group, but these changes were not significant from baseline and were not significant different between the placebo group and the semaglutide group. Looking at the other secondary endpoints, systolic blood pressure and body weight, semaglutide in this population reduced systolic blood pressure by 6 millimeter mercury compared to placebo. It reduced body weight by 9 kilogram after 24 weeks treatment compared to placebo. And we found a reduction in waist circumference with semaglutide of 4.4 centimeters. Semaglutide also reduced a high sensitivity CRP by 38% after 24 weeks treatment compared with placebo. We also conducted correlation analyses between the change in body weight and the change in estimated or measured GFR. And again, on the left, you can see the creatinine eGFR data, the dark blue line, the semaglutide-treated patients, and the light blue line, the placebo-treated patients. There were no correlations between the change in body weight and change in eGFR with creatinine, no correlations when eGFR was estimated with cystatin C, both in the placebo group and semaglutide group, and also no correlations with iohexol measured GFR. The safety of semaglutide in this population was consistent with the known safety profile of semaglutide. The most common adverse events were gastrointestinal related adverse events. And you can see them here. Constipation, diarrhea occurred more frequently in the semaglutide group compared to placebo. Nausea was more often reported in the semaglutide group compared to the placebo group. So in conclusion, in patients with chronic kidney disease, without diabetes and with overweight or obesity, treatment with semaglutide for 24 weeks led to a marked and consistent reduction in UACR, did not change eGFR or mGFR. Other significant positive effects on blood pressure, body weight, waist circumference, and hs-CRP were observed. Semaglutide was generally well tolerated with no newly reported side effects. This study supports a larger and longer study in chronic kidney disease patients. I would like to acknowledge and express my gratitude to all patients who participated in the trial. I acknowledge the support from many other people who have contributed to the trial, and the study was funded through a research grant from Novo Nordisk to my institution, and the funder had no role in the design, conduct, interpretation, or presentation of the result. These data are now published in Nature Medicine, where you can read the full results of the trial. And then finally, this cartoon appeared in a Dutch newspaper only a couple of days ago, and they probably knew that I was presenting the results of this study today. Thank you for your attention.
So we have a bunch of questions. So let's start with the effect on body weight. So is the reduction in albuminuria independent of the change in weight in this study?
That's a really good question. There was a modest correlation between the change in body weight and the change in albumin to creatinine ratio. Whether that just reflects that patients respond very well to body weight and in albuminuria, or whether the effect on albuminuria is explained by the change in body weight, we cannot infer from that analysis.
From a pharmacologic perspective, is 4 weeks enough time to wash out the semaglutide and assess its longer-term effects, especially given its half-life as well as the pharmacodynamic properties?
Yeah, definitely. 4 weeks is probably not enough because the half-life of semaglutide is more than a week, and you would probably need a longer follow-up to wash it out completely. On the other hand, a 52% reduction in albuminuria, you would expect after 4 weeks that some of the effect would return, and we did not see an effect because there was also an increase in the placebo group in albuminuria during the washout. So after 28 weeks, there was still a 50% difference between placebo and semaglutide. So probably there are other pharmacodynamic effects also playing a role, but we don't know exactly what kind of effects these are.
Along the same lines, it also reduces blood pressure. Is there any correlation between the blood pressure reduction and the albuminuria reduction?
There was no change in correlation between changes in blood pressure and albuminuria.
Okay. Going back to the obesity point of view, do you think the GLP-1RA effect is dependent on body mass index and obesity? And for example, would you propose a trial in proteinuric patients, but who are not obese and who are not diabetic?
Excellent question. Indeed, that is the question that we have to investigate. Are these drugs also effective in people with a BMI down to 25, 23? I would not recommend that I start using this drug because I would probably be that cartoon and would probably disappear. But we have to investigate whether these drugs can also protect the kidney in people with a lower BMI.
Okay. One last question. There are a bunch of questions about the interpretation of the GFR changes, and semaglutide. Would you add anything apart from what was presented on how would you interpret that?
Yeah, well, that is also a good question. I feel that I had expected that there would be a correlation between the creatinine or cystatin C GFR and body weight. There was absolutely no correlation. In fact, it tended to go the other way. with creatinine and eGFR. Maybe the reduction in body weight is not large enough to see that correlation. When you look at the other drugs like tirzepatide, reducing body weight by at least 10%, and when we correlate that with cystatin C or creatinine and eGFR changes, we also didn't find a correlation. Earlier this year, I presented data from the triple G agonist, retatrutide, where we found a correlation between changes in body weight and eGFR, but that drug reduced body weight by 25 kilograms. So maybe the 9 kilogram is not even enough to see that correlation, and you need profound reductions in body weight before you see the correlation.
Excellent. Thank you again for the presentation, and congratulations on the publication.
Thank you very much.
Thank you, and thank you to all the presenters for sticking to time. Our next presentation will be from Dr. Will Harrington on the long-term effects of empagliflozin in chronic kidney disease. Thank you, Will.
Thank you, Professor Jardine. Thank you, DSN, for the platform, this fabulous platform, to present the results of the EMPA-Kidney post-trial follow-up study, which I do on behalf of the collaborative group. EMPA-Kidney was a trial which was initiated by the University of Oxford, and we led its design and analysis and reporting with a steering committee of experts. It was funded by a grant to the University of Oxford by Boehringer Ingelheim and Eli Lilly. EMPA-Kidney was a large, simple trial. It was double-blind, placebo-controlled, and was designed to assess the effect of SGLT2 inhibition in a broad range of patients with chronic kidney disease at risk of progression. 6,609 patients were randomized, and we selected them with simple inclusion criteria, an eGFR between 20 and 45, or 45 to 90 with some degree of albuminuria, at least 200 milligrams per gram. So they were randomized simply 1-to-1 to empagliflozin 10 milligrams versus matching placebo, and they were followed for a primary outcome of cardiovascular death or kidney disease progression. And that was made up of the receipt of maintenance dialysis or a kidney transplant, which we refer to as end-stage kidney disease, or death from kidney failure, or eGFR components, important reductions of at least 40% from the baseline value or to less than 10, and that had to be sustained. And I think you all know the trial was stopped early and reported early after only 2 years of median follow-up, because empagliflozin was shown to safely reduce the risk of the primary outcome by 28%. We designed the post-trial follow-up study to assess whether or not there are carryover effects of empagliflozin, and also to allow us time to accrue more hard clinical outcomes which take longer to accrue, particularly end-stage kidney disease. And so after the active trial completed, surviving consenting participants continued to be observed for a period of 2 years after the end of the trial. No trial drug was issued during this period, but local doctors could prescribe an SGLT2 inhibitor if they considered it to be indicated and it was available. And the primary composite outcome was the same as in the active trial, but this time analysed from the point of randomisation all the way to the end of the post-trial follow-up period. During the active trial, 4 to 5% of our participants died, and 18% came from centres which didn't participate in the post-trial follow-up period. But we still had just under 5,000 participants who were followed for an additional 2 years. At the end of the trial, all participants that were randomised were analysed in an intention to treat analysis, with those which didn't enter the post-trial period essentially censored at the appropriate point in the active trial phase. And as a reminder, here are some of the characteristics. This is just restricted to the post-trial cohort. This is their baseline characteristics of randomisation, which are nicely balanced. And EMPA-Kidney represented the types of patients who we see in nephrology clinics who weren't represented particularly well by the previously reported SGLT2 inhibitor trials. And I want to draw your attention to the fact that nearly 60% of patients didn't have diabetes at baseline. We had just over a third with an eGFR less than 30, and we had nearly a half of the population with A1 or A2 levels of albuminuria. And throughout the follow-up periods, we maintained blinding to the original allocation groups. We've already reported that the average use of SGLT2 inhibitors in the active phase of the trial was on average 90% in the empagliflozin group, and we had 2% drop in the placebo group. So 90 versus 2%. We stopped the trial, we retrieved drug, and during the period of 2 years afterwards, we began to see open label use of SGLT2 inhibitors to the extent that on average it was 43% versus 40%. Now, this is an important number because it's not different, or it's not substantially different, and the loss of the difference between the groups means it enables our assessment to see if there's a carryover effect from original allocation to empagliflozin. And if there was no carryover effect, then hypothetically we would see the scenario on your left, which is that the Kaplan-Meier curves would slowly converge. If there was a carryover effect, we would see either the Kaplan-Meier curves being maintained, or if the effect, and only if the effect was large, would they diverge. And conversely, if there was some direct harm from stopping the trial drug, then they would converge more rapidly. This is the already reported result from the active trial. You know these results. It's 558 in the placebo arm versus 432 in the empagliflozin arm. That's the 28% risk reduction. A further 2 years of observation, and we now have 1,001 primary outcomes in the placebo group, 865 in the empagliflozin group. So that's a clear 21% relative reduction. And if you look at this on an absolute scale, then the absolute benefits appear to be maximal around 3 years from randomization at 52 fewer participants with a primary outcome per 1,000 allocated to empagliflozin. Now, it's difficult to see whether or not there's a carryover effect there, so we convert this onto a forest plot for you. So transposed here in the diamond is that overall result of the 4 years of follow-up. And you know the 28% relative risk reduction, the hazard ratio of 0.72 from the active phase of the trial. In the first year post-trial, we saw a 24% reduction in risk in people in the post-trial period. So these were people who stopped taking their study treatment, and we still saw a 24% reduction in risk. So this is ongoing cardiorenal benefits. But in the second and the very short third year in the post-trial period, that attenuated and there was no clear effect. So in aggregate over the 2-year post-trial follow-up period, there was a 13% risk reduction. What we see here is a carryover effect, an effect which lasts for about a year, but an effect which is smaller than taking the active drug. We really also wanted to collect more information on death and end-stage kidney disease, and this is the composite of those two outcomes over the entirety of the follow-up period, 648 versus 559 outcomes. In fact, the absolute benefits were maximal at the end of the 4-year follow-up period at 32 fewer deaths or end-stage kidney disease events per 1,000 allocated. And again, we convert this onto a forest plot for you so you can see the active trial and the carryover effect. And you can see there's a 21% reduction during the active trial and a further 18% reduction in the post-trial period. So really important effects, 648 versus 559, really important clinical outcomes. On the left, we now give you the kidney disease progression outcomes. That was 897 versus 778. Now, some of the post-trial benefits might be ascribed to the reversal of the small acute dip in eGFR when trial drug is discontinued. But that doesn't explain the effects on end-stage kidney disease, which are also found to carry over. So during the active trial, there's a 34% reduction in risk and then a further 20% reduction post-trial, a net effect of 2 years of empagliflozin followed for 4 years, reducing risk of end-stage kidney disease by a total of 26%. That's 372 people on dialysis versus 296. So these residual cardiorenal benefits are on hard clinical outcomes. Mortality-wise, we also accrued more deaths. 162 versus 126 is a quartering of the risk of this key part of the component of the primary outcome. This was a streamlined follow-up period after the trial, and this was the key safety outcome, non-cardiovascular mortality, no effect over the entirety of follow-up. And so the net effect on mortality is 336 versus 301 deaths from any cause. And then the last interesting insight from the post-trial follow-up period, a subgroup analysis of the primary outcome over the 4-year period. Now, this was all pre-specified and designed before we knew any of the results of the main trial. And you can see here that 21% relative risk reduction was consistent in people with and without diabetes. It's also consistent by primary kidney disease, consistent by diabetic kidney disease versus hypertensive renovascular disease versus glomerular disease versus other unknown causes. But there's also no evidence for effect modification by baseline level of kidney function or across the A1, A2, or A3 levels of albuminuria. So here are the key conclusions from the post-trial follow-up phase. 2 years of EMPA-KIDNEY post-trial follow-up found important residual cardiorenal benefits of empagliflozin after the trial drug was discontinued, and that included effects on end-stage kidney disease. But that carryover effect was only 13% over the 2 years, less than the 28% whilst taking empagliflozin. So what this means, it only lasts for 12 months or so, is that if we want to maximize the benefits of SGLT2 inhibitors, we need to start patients on them early, keep them on them, and not stop the drug. We need to maximize benefits. We need long-term treatment. But the almost doubling of the number of primary outcomes of 990 to 1,866 over the 4-year period helps address some of the uncertainties of the relatively short active trial period. We now see the relative benefits over the 4-year period are consistent across the key subgroups, particularly across levels of albuminuria and kidney function, and there was reduced risk of cardiovascular death with no effect on non-cardiovascular deaths. That's a very detailed set of results to present in almost 10 minutes, just over, Professor Jardine. But we have got a full report available for you now on the New England Journal of Medicine, and we'll provide these slides for you to use on our website in due course. And this is a rather poignant moment for us because it's our 8 years since we started this project. We've now completed the follow-up of the participants. We want to thank them again for their contribution and also thank the collaboration, which grew to over 1,600 members of the committees and coordinating centres and the local clinical staff that made up a collaborating group, which took on the mission of randomising large numbers of people in a simple trial design. We thank them for their support, both now and ongoing as we begin to expand the collaboration into new projects. Thank you for listening.
Congratulations on that discussion, on the fantastic presentation. So there's a lot of questions about the carryover effect and how come it lasts for a year because the blood pressure glucose lowering effect is gone. Does that reflect some ongoing benefit of empagliflozin or possibly that, so they're giving you an answer, is that possibly the patients on EMPA started the observational period in a better shape?
So we postulated and we set up post-trial follow-up because we thought that people on EMPA would start post-trial follow-up in a better shape, and that is still a possibility. Yes, we don't know the mechanism. The fact that there is benefits on end-stage kidney disease suggests there is some structural change or some benefit because if it was just reversal of the acute dip, then we wouldn't see that type of benefit.
Did you conduct any statistical test of heterogeneity for the results for the in-trial versus the post-trial period?
Yes. And I don't know what the question is being asked. So you're asking about a time interaction. Yes, there are time interactions which were tested. So if the question is there a significant difference between 28% and 13%, then the p-value is 0.05. So it's somewhere in the grey area.
Many people are unhappy about the fact that only 40% of the patients continued on SGLT2 inhibitors. Is there any reason why you think the fluosination uptake was so low? And just to clarify, patients could go on any SGLT2 inhibitor. It wasn't just empagliflozin.
Yes, patients could go on any SGLT2 inhibitor. By the end of the post-trial period, we had just over 50% of participants who weren't on kidney replacement therapy on an SGLT2 inhibitor. If you're a glass half full person, then that's great. We've got half of them treated, fantastic, and we've got somewhere to go. If you're a glass half empty, then you say we've still got a lot of way to proceed further. And that was despite the fact we had rapid review by regulators. I hope that some of the data here will address some of the uncertainties in certain groups of patients. but also we spent a lot of time trying to design this study to be streamlined. It's a rare feat to demonstrate post-trial follow-up of this duration. And I hope that the demonstration of the value of this data might mean that we can design better post-trial follow-up studies in the future, particularly ones where we can see patients in clinics and provide them with treatments long-term, so we can have open label extension studies and have all patients who tolerate the treatment continue it for a period of time after the trial.
So you did have a small number of patients who had type 1 diabetes, and there were also patients with albuminuria and with higher degrees of albuminuria. So was there any subgroup analysis done for this long-term data by these subgroups?
So the albuminuria subgroup was presented. There was no evidence of effect modification by level of albuminuria. In the report, there's also, we present kidney disease progression as an outcome by itself and by a level of albuminuria in the other key subgroups. We haven't analysed the 68 patients with type 1 diabetes. The patients with type 1 diabetes had an interesting EGFR slope analysis, and we did analyse that for the active trial. The results are consistent between type 1, type 2, and the non-diabetic groups. But we don't have sufficient data in this sub-study to be able to do that because we're not looking at slopes, we're looking at hard clinical outcomes.
Thank you.
Thank you. And so our next presentation now is from Dr. Bi-Cheng Liu on the efficacy and safety of HSK 21542 for moderate to severe CKD-associated pruritus, a phase 3 trial in hemodialysis patients. Thank you, Dr. Liu.
Good morning, ladies and gentlemen. It's really honor to be here on behalf of the investigators to present our work. And also thanks for the Kidney Week to invite me here. So my talk today is about efficacy and the safety of HSK 21542 for moderate to severe CKD-associated pruritus, a phase 3 trial in hemodialysis patients. So this is my disclosure. This study was funded by Haskell Pharmaceutical Company. So I will give talk in the following 5 parts. As we all know, CKD is a huge global health burden with high prevalence, deaths, and mortality. The most of the countries and regions, the prevalence of CKD is over 10%. And specifically, let's take the example of China and the USA. We have a large number of dialysis patients. In the past decade, our dialysis patients growing rapidly. Now we have nearly 1.1 million dialysis patients, and the annual increasing rate is 10%. As we all know, chronic kidney disease-associated pruritus or itching is a common and distressing condition that affects approximately 50 to 80% of patients with kidney failure who are on dialysis, and over 40% are moderate to severe pruritus. Patients with intense and generalized systemic itching are associated with a reduced quality of life and an increased risk of death. There is limited therapy for this vexing clinical problem so far. The mechanism of CKD-associated pruritus has not been fully understood. Many theories have been proposed to explain it, and serious risk factors are found to be involved in CKD-AP. Recently, the imbalance between MOR and KOR expression and their signaling pathway have been found to play an important role in the development of CKD-AP. So targeting KOR to develop the KOR agonist would be a new promising strategy for the moderate to severe CKD-AP. HSK was developed by Haskell Pharmaceutical Company in China. It is a small hydrophilic peptide targeting peripheral kappa opioid receptors with high selectivity and affinity. It is not able to penetrate to the blood-brain barrier. In the previous phase 1 and phase 2 studies, we have identified that the half-life of HSK on hemodialysis patients is 26, and the drug was excreted mainly from feces with a prototype. it was in the phase 2 study, it was demonstrated that the dosage at 0.3 microgram per kilogram per body weight could significantly reduce the intensity and of pruritus by evaluating WI-NRS score with good safety. So this study, the aim of this study was to evaluate the efficacy and the safety of intravenous given HSK on hemodialysis patients with moderate to severe pruritus. This is a multiple center randomized double-blind placebo-controlled phase 3 trial. So this is a flowchart of the study. Patients over 18 years, moderate to severe CKD-AP on the regular hemodialysis was screening, and they, after 7 days running, we measured the weekly mean score who are over 5 on the 24-hour WI-NRS was included in the study. Then the patients was randomizedly divided to 2 groups, HSK treatment group and a placebo group. After 12-week double-blind phase, the patients would further intended to the 40-week open-label extension phase, and all the patients was treated with HSK. This is the design of the study. The primary outcome of this study is to observe the percentage of patients with the improvement of at least 4 points from baseline at week 12 in the weekly mean score on the daily WI-NRS. And the secondary outcome is the percentage of patients with the improvement of at least 3 points from baseline at week 12 in the weekly mean score on the daily WI-NRS. And mean change from baseline at week 12 in each related quality of life as measured by SkinDex-10 and 5D questionnaires. And also mean change from baseline at week 1 to 12 in the weekly mean score on the daily WI-NRS. And the mean change from baseline at week 14 to open-label treatment in each related quality of life as measured by 5D each questionnaires. Safety assessment was also observed. So this is a patient flow. We can see 545 patients was randomized to the 2 groups and 243 on the HSK treatment group and 254 was completed the study in the placebo group, and totally about 376 complete the final extension stage. So this is the baseline characteristics. We can see all the parameters are quite similar in the 2 groups. Specifically, we can see that WI-NRS score was equivalent in both groups, and the SkinDex-10 scale total score, 5D each scale total score, all are similar in the 2 groups. So this is the results of the trial. For both primary and the secondary outcome, HSK-21542 treatment could significantly improve the percentage of reduction in WI-NRS score at week 12 compared to that in the placebo group. And the HSK-21542 also induced a significant improvement in mean WI-NRS, which was started at week 2 and sustained throughout the 12 weeks of treatment. And also we found that HSK-21542 could significantly improve the patient's quality of life, as shown in mean change in SkinDex-10 total score at week 12. During the 12 weeks double-blind period, HSK could significantly reduce this score compared to the placebo. Noticeably, the score is continually improved in both groups in the next 40 weeks open-label study. So in terms of the safety, we summarized here, we can see that both groups, in terms of the TEAE and the SAE, are quite similar. And but the TRAE, treatment-related adverse events, is slightly increased in HSK treatment group. And for those with dizziness, hypotension, for HSK group is a little bit higher compared to the placebo. And we have not found the significant difference between the two groups in terms of the incidence of central opioid-related adverse reactions and gastrointestinal adverse reactions. So generally, HSK-21542 was safe and well tolerated throughout the study. So I'll give a short discussion. Treatment of CKD-AP is still a challenging issue currently. Up to 40% of dialysis patients are suffering from moderate to severe pruritus. However, there is no recognized standard of care for CKD-AP. A large number of patients with severe pruritus are actually not accessible to the effective treatment. So the finding of imbalance between mu opioid receptor and the kappa opioid receptor and their signaling pathways in CKD-AP stimulates the development of KOR agonist as a potential therapy of CKD-AP. Now there are two types of kappa opioid receptor agonist, peripheral and central. So the kappa opioid receptor agonist could regulate the potassium and the calcium currents involved in G protein activation to block pain and itch signal transduction. It also can inhibit the excitability of dorsal root ganglia and peripheral sensory nerves, reducing the release of inflammatory factors and neurotransmitters. Previous clinical trials have demonstrated that both norepinephrine and difelikefalin could significantly improve the moderate to severe CKD-AP. In this phase 3 study, we demonstrated that the newly developed highly selective kappa opioid receptor agonist, HSK-21542, has a similar remarkable effects on CKD-AP in Chinese HD patients. And compared to norepinephrine, peripheral kappa opioid receptor agonist HSK-21542 showed with more safety advantages, particularly on the central opioid adverse reactions. So this is because the structural modification of HSK with spiraline. So HSK shows stronger agonistic activity through the increase in binding affinity with KOR. So now I would like to conclude my talk. This phase 3 clinical trial demonstrated that HSK-21542 could remarkably reduce the itch intensity and improve itch-related quality of life for patients with moderate to severe CKD-AP as compared with the placebo. HSK-21542 was generally safe and well tolerated for the long-term use, particularly quite low incidence of central opioid adverse reactions. This study suggested that HSK-21542 as a new selective KOR agonist will be an optimal solution for moderate to severe CKD-AP. Finally, I would like to thank all the investigators and the patients involved. Thanks for your attention.
So congratulations on conducting that very large study in hemodialysis. We have a couple of questions. The effect on the scale is statistically significant. Do you have any sense of if the change in pruritus is clinically significant as well? Does it correlate with a symptomatic improvement in patients?
Maybe. We all know that quite a lot of factors may affect, associate with the pruritus in CKD, So anti-inflammatory effect, maybe, yeah.
And one last question. Do you have any data on how long the benefits last after the drug is stopped?
We just follow up 1 week after stopping the treatment. So maybe in the future, it's a good question, I think.
Okay. Yeah. Thank you again for the wonderful presentation.
Thank you.
Well, thank you everyone for staying to the end of this great session. Our last presentation is from Dr. Fei Liu on the efficacy and safety of tacrolimus or MMF for children with steroid-sensitive but frequent relapse or steroid-dependent nephrotic syndrome, a nationwide multi-centre randomised study. And this will be presented with a discussant presentation from Keisha Gibson. Thanks very much, Dr. Liu.
Well, good morning, everyone. Thanks for the Asian's invitation. I feel honored to give this presentation where our pediatric nephrologist may feel a little bit tired of the adults study, so I bring this children's study. My topic is efficiency and safety of tacrolimus or MMF for children with frequent relapse nephrotic syndrome or steroid-dependent nephrotic syndrome, a nationwide multi-center randomized study. Here is my disclosures. I'll start with the significance and background. As we all know, the idiopathic nephrotic syndrome is the most prevalent glomerular disease in children, with the incidence about 3 per 100,000 children annually, and nearly 90%. And the first line therapy of this disease is corticosteroid, and about 90% of them is steroid sensitive. But unfortunately, nearly half of them will develop to frequent relapse or steroid dependent, which pose great challenges to our pediatric nephrologists. So how to treat this situation? The clinical practice guidelines recommend that steroid sparing agents be prescribed in this FRNS or SDNS. And recently, the IPNA guidelines also suggest the steroid sparing agents in FRNS or SDNS. But there is an important question. There's no sufficient evidence to establish the best inertial option and to optimal sequence of agents from most to least effect and least to most toxic. From this table, we can see that there have been few studies focused on the use of tacrolimus or MMF on these two diseases. But we can see that these studies are neither single center, small samples, or retrospective study, so cannot give us robust evidence. So we conduct these large sample ICT studies to compare the efficiency and the safety of tacrolimus or MF, these two mainly used steroid sparing agents for children with FRNS or SDNS. And we hope to provide evidence-based data for future guidelines. Let's see the methods. 12 tertiary children's hospitals in China and 1 clinical epidemiology and clinical trial unit participants in this study. And our study was from November 2019 to July 2023. The entry criteria: these patients should be diagnosed as FRNS or SDNS and age from 2 to 19 years old. And the eGFR should more than 20 milliliter per meter per 1.73 meter square. And at the time of enrollment, the patients should be in the remission stage. And they should have no use of tacrolimus, MMF, cyclosporine, ITX, or CTX within 2 years before enrollment. And here is the exclusion criteria. includes steroid-resistant nephrotic syndrome, a family history of nephrotic syndrome, chronic glomerulonephritis or uremia, and other exclusion items similar to other top studies. Once the patients were enrolled, they would be given tacrolimus or MMF alongside with the steroid. The initial dose of tacrolimus was 0.025 to 0.05 milligram per kilogram twice daily. And in the first 6 months, the trough concentration of the tacrolimus ranged from 5 to 10 nanogram per milliliter. And in the next 6 months, less than 5 is permitted. As for the MMF, the initial dose was 10 to 12 milligram per kilogram orally twice daily. And the MPA AUC should be ranged from 30 to 50. As for the steroid, the initial dose is 1 to 1.5 milligram every other day, or 0.5 to 0.75 milligram per kilogram every day. And the dose should be gradually reduced after 4 weeks. And finally, maintain at a low dose until this study is completed. And the total follow-up period of our study was 1 year, with visits at the first, 4th, and 8th week, and then once every 8 weeks until 40 weeks, and the last visit at week 42. And we monitored the number of relapse, cumulative steroid dose, AEs, tacrolimus and MPA concentration, and the laboratory tests. The primary outcome was 1 year relapse-free survival. The secondary outcomes composed of relapse frequency, the first relapse time, the relapse-free survival rate in the first 6 months, and the cumulative steroid dosing. The safety outcomes include changes of vital signs and various index in laboratory examination, such as blood and urine routine tests, liver function, renal function, ECG, checks X-ray examination, and the clinical reported AEs and adverse reactions. Results. 292 patients were screened for eligibility, and 270 patients were randomized to tacrolimus group and MMF group. And finally, 129 patients finished the tacrolimus treatment, and 114 patients finished the MF group. From this table, we can see that the demographic and the clinical characters of these two groups were balanced. From these two figures, we can see that the cumulative incidence of tacrolimus group significant higher than the MF group. And the 1 year relapse rate in tacrolimus group was less than the MF group. And this all had a significant statistical difference. And from this forest plot, the tacrolimus group showed priority in all the subgroup analyses based on the age 6, age 8, disease onset, and the duration of disease. As for the secondary endpoints, time to first relapse after enrollment in tacrolimus group was 225 days, and in the MF group was 164.5 days. And total number of relapse within 1 year in tacrolimus group was 0.32, minor plus 0.92, and in the MF group was 0.79 plus and minus 1.97. And the number of people who relapsed within 6 months after enrollment in the tacrolimus group was 8 times, and in the MF group was 34 times. And the tacrolimus group also had a low average total steroid use and low average total steroid use per unit body weight. This all had the significant statistical difference. As for the AE, the incidence of AE in tacrolimus group was 94.8% compared with the MF group, 92.6%. About the SAE in the tacrolimus group was 66.7% compared with MF group, 71.4%. But this result has no statistical differences. So the conclusion, in children with FRNS or SDNS, a 1-year course of tacrolimus therapy significantly extended the period of relapse-free survival in comparison with comparison to MF group, and the tacrolimus group also had few annual and reduced cumulative dose of steroid than did the MF group. And the safety profile in both groups was similar. What's next? The total follow-up of our study was only 1 year, so we intend to evaluate the long-term safety profile in future, and we want to observe the discontinuation outcomes. And all the patients were from China, so we want to cooperate with other researchers to evaluate these findings across diverse ethnic populations, and we want to explore the impact on quality of lives. And finally, I want to acknowledgement to all the patients enrolled and their families, and all the PI, sub-PI, pharmacists. And we thank Hangzhou Zhongmei Huadong company to sponsor this study. And we thank all the CIC, CRO, and all the consultants. Finally, I want to mention that our study went through the COVID-19 epidemic. All the participants overcome a lot of difficulties. So I want to thank them again. Thanks for your listening.
Now I'll ask Dr. Keisha Gibson to come to the stage and give her discussion.
All right, good afternoon, everyone. I recognize that I'm in a precarious position standing before you in lunch, and so I promise that I will be succinct with this. I just want to make note of my disclosures here, in particular, the one that I was a member of the KDIGO 2021 Glomerulonephritis Guidelines Writing Group. So I was charged, first I want to thank our moderators for the invitation to comment on this very important study. I was charged to provide, or emphasize rather, context behind the importance of studies like this and to think a little bit about how this may impact my practice. And so I always think that it's helpful to put the patient in our mind as we're thinking about these trials. So I'm going to give you a 4-year-old with idiopathic nephrotic syndrome. This is her first presentation. She started on 2 mg per kg per day of prednisolone. And like so many of these steroid-sensitive children, promptly went into remission after 5 days. Aligned with current guidelines, she completed 6 weeks at this dose and then was weaned down to 1.5 mg per kg per day, alternate days for an additional 6 weeks. Now, unfortunately for this young lady, that despite the absence of an identifiable trigger, she relapsed twice within 2 weeks of discontinuing her steroid taper. She's maintained a remission now for about 8 months, but on alternate day prednisone and requires at least 1 milligram per kilogram per day to stay in remission. In addition to significant weight gain, her parents are now distressed over her mood swings, so we now see a direct impact on her mental health. And the question to you as a provider is, what would you recommend next to this family? So we're thinking about this young lady who is steroid responsive, but now is displaying complications to this treatment. So we look to help from our current practice guidelines. So the KDIGO 2021 guidelines, just to reemphasize, would say in this scenario, children with frequent relapsing nephrotic syndrome who develop a steroid-related adverse event, and for all children that are diagnosed as steroid-dependent nephrotic syndrome, that we recommend that steroid-sparing therapies be employed rather than no treatment or just continue with steroids alone. And then the following year, IPNA 2022 came out with recommendations for children with steroid-sensitive nephrotic syndrome, and this represented a much broader group of our pediatric nephrology community. And they recommended that in situations of a patient with steroid-sensitive nephrotic syndrome who's not controlled on therapy, who suffered a complicated relapse, or just meets the diagnosis of steroid-dependent nephrotic syndrome. So not even waiting for that complication of steroid toxicity, but as soon as they meet that diagnosis of steroid dependence, that we should be considering steroid-sparing therapy. And so just to reemphasize this graph that Dr. Liu presented, in this scenario, we understand that we want to go to a steroid-sparing therapy, but I want to highlight this box. Because in this box, it represents that as a guideline writing community, at the best, we could offer the list of steroid-sparing therapies that are available, but give them to you in alphabetical order. Not in the order of which one would be the most effective for this patient, not in the order of which one may be least toxic, but leave it to the patient and the physician to have a conversation about their preferences. Perhaps there may be issues with availability in the United States. Levamisole, for instance, is not available. But really no really well done, rigorous clinical trials to help us understand which one may be more effective than another. So very excited to see this study. I think it's important to point out, I say limitations, but I really want to say more nuances to keep in mind. As Dr. Liu already pointed out, of course, needs to be replicated in more diverse populations. I want to point out that the targeted tacrolimus trough levels in this study were a little bit higher than current guidelines. So the current study targeted levels of 5 to 10, and our guidelines, the target level is 3 to 7. And then the AUC achieved target in this study was 30 to 50. And that also is a little bit lower than what we're currently recommending. And the reason for that is based upon this 2013 study out of Germany that primarily wanted to assess whether MMF or cyclosporin would be more effective in preventing relapses. And similar to the current study, they showed that mycophenolate mofetil performed at a more inferior level, that there were more relapses found in that group. But what was really important in this study is that on a post hoc analysis, they looked at the children that achieved an AUC under 50 and those that achieved an AUC above 50 and found a statistically significant difference in those groups. So in the children that achieved an AUC above 50, there were only 0.27 relapses per year compared to those less than 50 of 2.7 relapses, or 1.4, relapses per year. And so the cumulative exposure there probably does matter. Now, keeping those nuances in mind, the authors of this study should absolutely be congratulated. This is a very large randomized trial, which is very difficult to do in the rare kidney disease space. The inclusion of prospective drug monitoring provides valuable information. So while I pointed out the nuance that the AUC targets were a little bit lower, for me, that just really adds to the evidence that if we're going to choose MMF for therapy, we really need to think about pushing that dose to achieve that target, or at least we know that achieving a lower AUC target may not get us the effect that we're looking for. I applaud that the authors here standardized the prednisone protocol. We have several randomized, non-randomized trials that were less transparent in the prednisone dosing here. And so I think that this was very valuable information to have. And the fact that there were higher tacrolimus targets in this study also adds a little bit of reassurance to us that the initial barriers that some of us may have with using calcineurin inhibitors in regards to the safety profile may not be as warranted. So again, I really applaud the authors for this study, even with the nuances that I've pointed out. This absolutely provides more valuable information to our community, and I definitely hope to see more.
Thank you so much. Well, that draws our session to a close. I'd like to thank you all for staying to the end, those of you in the room, and remind you that there is a repeat session tomorrow, same time, same place. Look forward to seeing you all then. Thank you.